We're going to tell you about our experience from introduction of a suite of machines with end-tidal control functionality to a medium-sized hospital in Melbourne, where I work. This is a very simple and quite low-tech approach to the problem, but it's a very real-world test of just what sort of change to cost and consumption you can expect to see from introduction of this technology where it previously wasn't present. This was Stanley Che actually was the driver of this project. This was done about 3 years ago, published in Anaesthesia Intensive Care a year or two ago, and Stan was actually working with us as a final year anaesthetic fellow. He was seconded to the Northern Hospital, where he very creatively decided to take advantage of the synergism of his arrival and the planned replacement of the machines there to look at the effect on costs. So, as has been mentioned, costs of healthcare are substantial and really are increasing out of proportion to the increase in workload that we're experiencing for various reasons to do with increased cost of technology, probably a more difficult ageing population, all sorts of reasons. We've spoken about the greenhouse gas implications of the work we do, and there is some evidence from previous publications that automated control systems are associated with decreased volatile agent consumption, at least with published data from the Draeger Zeus. So we thought that we would also look at this with the GE ACES machine. The hypothesis of the project was that introduction of automated targeted low flow technology would reduce cost and consumption of volatile agent specifically compared to conventional practice. And this was a very simply designed effectiveness study with a before and after study design. The Northern Hospital is a 400-bed teaching hospital associated with the University of Melbourne. It practices a wide variety of surgery, not cardiac or neuro. There are 6 operating theatres which run fairly busily all year with over 10,000 surgical cases per year. So it's a nice encapsulated environment to actually go examine the effect of this change in equipment. And they were scheduled to upgrade their previous GE. They had an Estiva system, I think, previously, and they were going to replace them with the ACES care station with end-tidal control functionality. It was estimated that volatile agent expenditure in the previous financial year had been $150,000 at the Northern with that sort of workload. So Stan arranged ethics approval before his arrival there as a fellow. Essentially there were two 12-week periods. The before period where data was collected, which is what we've called the manual period. Then after the new machines were brought in, there was an 8-week period allowed for the standard education, familiarisation of the anaesthesia staff with the new machinery, and then another 12-week period of collection of data, which we call the end-tidal control period. And then in addition, just to try and look for the potential confounding effects of a change in workload or a change in case mix occurring during this period of time, data from the identical 12-week period in the previous year was looked at to see if there was any changes. And in fact, there were some changes, which I'll talk about in a minute, which sort of modify the findings to some extent. Basically, the idea was to capture all general anaesthesia, which was going to be done with a volatile anaesthetic agent. The primary endpoint of the study was measurement of volatile agent costs and consumption, but we also looked at the global warming potential of any change in usage, CO2 absorbent usage, and changes in the costs of the fresh gas carrier gases as well. Essentially, the primary variable that was being collected was the number of bottles of each of the 3 volatile agents that was being replaced in the pharmacy impressed in the operating theatre by the main pharmacy each week. So it's a very simple number that was being counted. Fresh gas supplies were measured by collecting data from the supply department. And the anaesthetists were asked to fill out, as often as they could when they were doing a GA, a voluntary case report form where they were asked some simple questions about their usage of the entitled control functionality and reasons why they didn't use it, and any comments or concerns they had with it. And also to record the fresh gas flow rates that they used. Most of the data on the patient demographics was collected from their electronic operating anaesthesia record. So this was the caseload during this period of time. Basically, there were 5,500 eligible general anaesthesia cases that were included, and of these, about 1,800 were in the manual phase beforehand, another 1,800 in the entitled control phase after the introduction, and then there are 1,800 cases examined from the records of the previous year, the seasonal group. And these are the results. The costs per hour of volatile agent usage were calculated, I won't go into details of the formula, but it's a fairly common sense exercise. That essentially the cost per hour of overall volatile agent consumption dropped from $18 Australian 72 cents to $13.77, which was a statistically significant drop. And the calculations as to the GWP 100 per hour of general anaesthesia also fell, and both of those were statistically significant falls. It was interesting that the change, although these differences aren't statistically significant, the change seemed to be less compared with the same time the previous year. And the reason for that is because there's been a progressive increase in the proportion of general anaesthesia done with desflurane at the Northern, and I think that reflects a widespread trend in clinical practice in Australia. I don't think the Northern's any different in that regard. So desflurane unit costs are a lot higher for various reasons. It's you use a larger volume of it for the same MAC hours, and so that actually modified the difference that we were seeing to some extent. There was no statistically significant change in the usage of sodium resorber at the time. I can't actually tell you which one we use, I think it's whatever was the standard supplied with the GE machine. So it did go up by about 7%, but that difference didn't reach statistical significance. Nor was there a significant difference in the overall cost and volumes of fresh gases that were consumed during that time. The reason being that air costs are negligible, oxygen costs are quite low, nitrous oxide costs are relatively low, and we're not using as much nitrous oxide as we used to. So that overall, the total costs, fresh gas costs, were very small compared with the cost of the volatile agents that were being used, and none of that reached statistical significance. I've spoken about the effect of the trend towards increased desflurane usage on these numbers. But probably, if you take that into account, the effect of the overall cost savings that were achieved by the entitled control system were probably underestimated to some extent by these numbers. The case report forms that were returned provided a few insights into the way that the new system was being used. The take-up was actually reasonably good. About 2/3 of cases, a CRF was filled in by the anaesthetist, which was quite good, really. I thought quite good return rate on the feedback forms. But in actual fact, in most of these cases, when the form was filled out, it was because the entitled system was being used. So a very small proportion of the CRFs that were returned were returned where entitled control was not used. Clearly, where the entitled control system was used, there was a much lower rate of fresh gas flow rate than was what was used in its absence. And probably all this 35% of CRFs that were not returned were probably returned because the anaesthetist wasn't interested in using the entitled control system at all. So it's a bit of a biased analysis, that I have to admit, but it does suggest that probably flow rates were being run at a much lower rate than was the case beforehand. So in discussion, I think the the adoption rate of end-tidal control was incomplete, but was reasonably good considering it was a brand new technology that was probably unfamiliar to many of the anaesthetic staff, many of whom are visiting staff. They're not full-time staff, and may have felt that they weren't familiarised sufficiently with the new system to use it routinely. Some of the barriers to use of an end-tidal control system that were reported included things like just forgetting to do it. Quick surgical cases. They do a fair amount of paediatrics there, where it was not their default practice to use a circle system in a lot of the paediatric stuff that they do. They prefer to use a Mapleson F system. And some people express concerns about the use of low flows and sevoflurane because of compound A issues, which probably aren't that relevant to be perfectly honest. So obviously this simple before and after design, it's not a very controlled situation. It's no randomisation of practice involved in this study design. But I do think this is a very simple and robust effectiveness test of what happens in a typical busy public hospital when you get technology and you stick it in there and just go through the normal process of introduction and familiarisation. This is the sort of, probably I would have thought, fairly minimum response that you can expect from the change in practice that can be achieved by this technology. You can ask the question, could the same sort of reduction in cost and consumption be achieved in the absence of an automated system? In other words, going through introduction of a campaign to encourage manual low flow management. And look, that's a debate that obviously we can have, and in fact it has been had in the past by a number of commentators. There are one or two studies which suggest that you can achieve equal improvements in efficiency by mounting a campaign of education and training and awareness protocol design for manual low flow controls to reduce your fresh gas flow rates. However, there's also data to suggest that while that's all very well and good, to maintain that effect in the long term is much harder, and that the initial improvements that you can achieve tend to fade with time in a way which is entirely human, and in a way that's why we have machines, so they can just do these things for us and maintain that change in practice and that vigilance in a way that humans aren't very good at over the longer term. It would be interesting, I think, to do a follow-up study of what's being achieved, practice now at the same hospital 1 or 2 years later, to see if they're still using the end-tidal control functionality in the same way and whether the same reductions in consumption are being achieved. And that's something that we will probably do in the near future. So in conclusion, certainly in this simple real-world test, introduction of end-tidal control significantly reduced. Costs, the savings per 10,000 GA hours here were about $50,000 Australian. Sort of pays for one machine per year or so, and it would certainly appear to be cost efficient from that in that regard alone. And the greenhouse gas savings were also quite substantial. I suspect that greater savings still can be generated from further, more widespread availability and familiarity with these systems. As they become more familiar to us, I think we'll actually be more willing to use them on a routine basis. And there are other savings to be made by rationalising the choice of our volatile agents. We're not just stuck with sevoflurane and desflurane. Isoflurane has some advantages still, and can, if it's used skillfully and intelligently, probably can be a useful part of achieving cost reductions, because it's a good deal cheaper in Australia than the other two agents, particularly much cheaper than desflurane. Yes, thanks very much.